Hi, I'm ready.
Okay.
Hello, everybody. My name is Dr. Khalili, and I'm doing my rotations currently in neurology with AMIQT. And today I chose to talk about a topic that is, it's not a classic case study. It's about my senior thesis that I wrote and submitted in July 2025. I'm from Austria, so we are required to write up a thesis as a requirement for graduating from med school. And the topic is about palliative care and advanced stage MS. When you hear of palliative care, usually you make the association with end stage oncological disease, right? Um, but when it comes to advanced stages of MS, people still have a hard time to understand the uses, the benefits for patients with this kind of disease. Um, that was the official title of my thesis. It's pretty long, but it's important to understand that our objectives were, on the one hand, the ascertainment, and on the other hand, the evaluation of the potential of palliative care in advanced stage MS. Advanced stage MS, I mean, it really depends on what kinds of definitions you look at. There's a lot of data, a lot of papers, studies out there that, they have their specific definitions, but I will go into that once we talk about the methodology of the study we did, which was in fact a retrospective study and was also a pilot study, right? So what is a pilot study? A pilot study is just a way of looking into this field and maybe propose improvements for future studies that have even more validity, right? Like longitudinal studies, RCTs, etc. So just a little background and motivation on my part. So I don't really need to go into details regarding the various definitions there are about multiple sclerosis. You should know in general that it is a autoimmune mediated neurodegenerative or demyelinating disease. There are, of course, various phenotypes. You probably know that there's relapse remitting, there's secondary progressive. But independent of that, we should also recognize that MS over a long period of time has a progressive trajectory. There are, very good medication out there that have an impact on disease activity, but still, when it comes to disease progression, unfortunately, there is, there is not much impact on that over time, right? And all of these phenotypes that I just mentioned, at some point, they lead to these so-called advanced stages. And as I said, I will go into more detail how we actually defined advanced stages of MS. But you should also acknowledge the fact that, of course, when it comes to advanced levels, just like with any other disease, or especially the neurological diseases, there's a high degree of usually physical disability, there's cognitive impairment, and also something that, in my opinion at least, does not get the credit it deserves or the attention that it deserves, are psychological disorders, right? I mean, with any kind of disease that has a huge impact on your life, there's also the psychological toll of suffering from this kind of disease. But despite all of that, I shortly mentioned that at the beginning, despite all of that, palliative care, best supportive care, whatever you want to call it, is still kind of marginalized when it comes to the MS treatment continuum. Because, I mean, you can understand to some extent, especially patients, when they hear palliative care, it always, is a we could say a trigger for them. They don't like to talk about it because usually it means, oh, death is imminent and there's not much we can do. But it's not true. And I will talk about that at the end, when I talk about my own perspectives and my own takes from this study. But palliative care basically means that we have to accept the fact that we are dealing with incurable disease, and we are not focusing on the cure, but we focus on providing the patients with best supportive care or providing them best possible quality of life. And there are various methods. And when I talk about palliative care in the context of this study, I refer to structured palliative care, holistic care, not just caring about somatic symptoms, neurological signs and symptoms, but also there's a lot more to the patient. There are, as I said, there's psychological distress, but also there are social issues that can affect the patients, right? When you think about the caregivers, when you think about the family members, when you think about all the other people who are actually involved in dealing with this disease, and also, of course, us, the professionals, right? Doctors, nurses, etc. So we had to obviously formulate some research questions that will also guide you to understand the key findings of the studies. So first of all, we just wanted to start very basic. Okay, so when we talk about high degree of disability and all huge impact on their lives, so we're really interested, first of all, in looking at the most common signs and symptoms, which are typical for advanced stage MS patients. And as I said, not just somatic, not just pain, paralysis, etc., but also affective disorders like depression, for instance, and anxiety, general well-being, and general satisfaction with their care, and so forth. This is also a very important question when looking at our participants. We wanted to know, okay, we wanted to know what kinds of treatments actually are there, that could meet the so-called holistic needs or potentially palliative care needs of these patients, okay? Is it just medication, or is it also neurorehabilitation? Is it also, bladder and bowel movement? We will see in the key findings that this is a major issue, and there are, surgical interventions, for instance, as well. Also like catheterization, PEG tube placement, and all that. And all of this is relevant in order to assess whether these needs of these patients are sufficiently met. And then, most importantly, where do we go from there, right? So how can we actually improve the assessment for palliative care intervention in advanced stage MS? Not just, because it's designed as a pilot study, so not just when it comes to research, but what about the clinical setting, right? This is in the end what we all care about. How can we apply all of that in the hospital setting, in the outpatient setting, right? And what we did, so our study took place in Lower Austria, at the University Hospital of St. Pölten, which is close by Vienna. It's a big university hospital at the Department of Neurology. And it was designed as a 10-year retrospective observational study with 59 participants, okay? And the 10-year span actually refers to the clinical records of these participants that were produced over time by various consulting neurologists, family practitioners, and all that. And this is something that I need to make perfectly clear, because we did not involve the patients directly, right? So it was a purely retrospective observational study based on the information that we extracted from clinical records. You could call it a design flaw, but you could also call it part of the plan, because we also wanted to see how extensive is the awareness of professionals, actually, of physicians that are dealing with these patients, right? And the main inclusion criteria was an EDSS of equal or greater than 8. The EDSS stands for Expanded Disability Status Scale. It is a very, commonly used scale in order to determine the degree of physical disability, the main determinant being restrictions in mobility, right? So usually goes from 0 to 10. 0 means perfectly fine, no restrictions at all, and 10 is actually death due to MS or complications related to MS. Anything above 5, 5.5, 6 is considered to be, a considerable degree of physical disability. EDSS 8, 9, so 8 means these are patients who are permanently confined or permanently wheelchair bound, and 9 is being permanently confined to bed. Okay. I'm not a huge fan of the EDSS. I gotta admit that, because it solely focuses on mobility and misses the part of MS being a multifactorial disease, a multidimensional disease, I call it. But it is a very straightforward method in order to assess the degree of physical impairment, right? Then what kind of information do we want to extract from the clinical records that were produced by the neurologists, by the consulting neurologist? So first of all, keep the originally stated research questions in mind. So first of all, we wanted to know, what are the signs and symptoms? What is the symptom burden? Then we also cared about treatments and also care modalities. So were they taken care of at home, for instance, by professional caregivers, by family members, and so forth, or were they accommodated in specialized care facilities, for instance? And all of that was extracted from these clinical records and categorized into somatic, psychiatric, and social parameters, right? And our main inspiration for that is the so-called IPOS, which stands for Integrated Palliative Care Outcome Scale, which is a kind of a newly developed scale that looks for the the importance of, or the urgency of, maybe going into palliative care or applying palliative care management. I will show you in a minute what it actually looks like. It is a patient-reported questionnaire with an ordinal scale, which is numerically coded. So it lists various signs and symptoms, and the patients are then asked about whether these symptoms are present and to what extent did they have an impact on their daily lives over the last 3 days. So it's not a long-term assessment, but kind of a short-term outpatient style assessment tool. But you will see in a minute what it actually looks like. And this is what I already said. So we mainly cared about somatic, psychiatric, and social care parameters. On this slide, on the left, you see the IPOS. It's kind of extensive. There are a lot of questions, but it's important to keep in mind that we use the IPOS as an inspiration because it uses that categorization, which doesn't only focus on somatic symptoms, but it also goes on and talks about psychological well-being, psychiatric issues. So do you feel any kind of anxiety, or are you satisfied with your current care regimen? And then they're supposed to rate it from 0 to 4. 0 means not at all an issue, not at all of an impact on my daily activities over the last 3 days. And 4 means I'm overwhelmingly restricted in my daily activities due to these symptoms. We simplify it a bit, right? I mean, using the IPOS would require a totally different study design, totally different statistics and so forth. But we use the categorization of the IPOS for our own parameter list, for our study-specific parameter list. You see that on the right. I mean, of course, we have general information. Under general information, we have the types of treatment. We will see that when we look at the key findings of it. But you see there are various symptoms listed, various signs and symptoms that could affect the patients with advanced stage MS. And then it's also important to point out that this parameter list is purely descriptive. So we were looking for these signs and symptoms in the records, and if found, we took note, we specifically described, explained what the consulting neurologist actually was referring to, or specifically referring to. So when it comes to paresis, paralysis, or was it monoparesis, was it tetraparesis, was it hemiparesis, right? So we had to be very specific. And these were our key findings. So the most common sign, the first part of the most common signs, that goes without saying that, you know, across the cohort, we observed severe physical disability, right? I mean, if you state the inclusion criteria of equal to greater 8, you can expect that, obviously. But it's still, I think, important to have a clear frequency distribution, right? So 63% of our participants, they were wheelchair bound, and 27% were bedridden. You know, there's a smaller percentage of people who, you know, could maybe even be mobile for a very short period of time, but you can see that physical impairment, severe physical disability was dominating. But when we go into the specifics of signs and symptoms regarding motor dysfunction, we saw that spasticity, for instance, 71%, you know, was the dominant issue, but also tetraparesis, paraplegia, and so forth. And on the right, you see, you know, with the table on the right, you see the specific signs and symptoms regarding plegia and paresis. Also, I already touched on it at the beginning, psychiatric issues. 50% of our participants, they had in their clinical records some report of physical disorder, with depression being most common. A lot of these people, a lot of these records did not take note of psychological disorders. Two reasons. Could be two reasons, most likely. One reason being it wasn't an issue, okay? Second reason being it is in fact an issue, but people being tasked of, you know, examining the patients, asking about the history and so forth, they did not emphasize it, or they did not, I don't want to say they did not care, but I would probably put it in the way of saying they didn't focus on it as much, right, compared to somatic symptoms. Also, bladder bowel dysfunction was overwhelmingly present. I mean, it's a neurological disease at the advanced stages. It's not surprising, but still, I think that with 71% requiring catheterization, suprapubic catheterization, self-catheterization, and so forth. And also, PEG tube placement was also very common due to swallowing difficulties, for instance, right? Malnutrition. Then going forward to our second research question, okay, which was about, so what kinds of treatments are there? How are the needs of this cohorts? How are they actually met by the current regimen of care? So of course, there's still heavy reliance on pharmacological therapy. These are patients who are not getting any immunomodulating therapy anymore, right? So this is purely symptom management. And you saw that on the slides before, 71% reporting spasticity, so muscle relaxants like baclofen, for instance. So a lot of people had baclofen pumps, right? Muscle relaxants were the most dominant kind of medication that we're receiving, 61%. But also, you know, when thinking of the psychological issues, the psychological impact, also, you know, some physicians even prescribe antidepressants as painkillers, right? But 31% using antidepressants like SSRIs, for instance, and also cannabinoids or anticonvulsants. Another major topic when it comes to the treatment regimen was rehabilitation, specifically neurorehabilitation, okay? Unfortunately, most patients did not report anything on rehabilitation or neurorehabilitation. Same thing, two reasons. Either they actually factually did not receive that kind of treatment, or the people tasked with taking note of it, examining the patient, actually did not focus as much on neurorehabilitation. But nevertheless, neurorehabilitation is the overarching term. So physiotherapy is part of it, therapeutic gymnastics is part of it. So physiotherapy was most commonly used, in fact. But I want to emphasize that again. I want to state that the interventions that were used, especially in regards to neurorehabilitation, were not standardized, right? Or consistently documented. This is very important. Yeah, they were not consistently documented because either, we didn't care as much, or in fact, it didn't affect these participants at all. Yeah, and it's hard to trace that back, obviously, right? And then another major finding was the modes of care that were relevant to these participants. So, in fact, at-home family care, or 24-hour care at home, was the most common form of care, basically, or care type, you could say, with 82% receiving at-home family care, either by family members, or professional caregivers. And only 50% were accommodated in specialized care facilities, which I think is pretty remarkable, right? You expect these numbers to be higher, right? And also, in only 2%, we saw the active utilization of structured palliative care. In those cases, there was a specific mentioning of palliative care in their records and a description of how they're receiving that type of care, right? So palliative care being marginalized in the MS care continuum. This is where we actually found, a kind of a confirmation of our originally stated hypothesis. And something else that I think needs to be addressed very properly is psychosocial support, not just for the participants, but also, for the caregivers, for the family members, of how are they actually dealing with the disease. That was largely absent, right? So we did not have any information on how these people are actually doing, right? And whether they receive any kind of support structure, right? And now moving on to the last question, which was about, recommendations. How can we actually improve the assessment for palliative care in this cohort? So first of all, yeah, our sample size was relatively small. Yeah, it was okay for a pilot study, but that, of course, restricts generalizability, right? So in the future, if future studies want to keep focusing on this, they should obviously include larger or even multi-center cohorts. I mean, we did a monocentric study, right? The second one is a very big one, right? And you can, as I said, you can call it a flaw, which it is. It is a flaw in our study design. But the idea was to also raise awareness among the people who are actually responsible for producing these records, right? But a way more valid approach would be to do a prospective longitudinal study, right? Where we use standardized tool. That's why I actually showed you guys the IPOS. If you use the IPOS as a standardized tool, then you can easily conduct prospective longitudinal data collection. That goes without saying. I think the lack of control comparison group, it was a retrospective observational study with no control. But if we go on, we should definitely maybe even do RCTs at some point, where we use palliative care as a intervention and compare that to a control group. Yeah, it was limited to Lower Austria, of course. I mean, there's also the issue of geographic generalizability. So can be quite different. The results can be quite different if we were to conduct the study maybe in the United States. But yeah, so we need definitely broader geographic inclusion, especially when we go on and want to formulate some changes in our healthcare system, national policies and so forth. And another big one, the patient-reported outcomes, right? So we cannot make a statement on how patients actually perceive the symptoms, perceive their treatments and so forth. So that was a big flaw in our study, obviously, right? And that is why we could use the IPOS, which is a patient-reported questionnaire in the future for more credible, more valid studies, right? So that relates back to the second point that I made about the prospective design, longitudinal data collection for future studies. But what is the conclusion? That's my final slide. So when it comes to our findings, we revealed fragmentation in both the documentation and the provision of holistic care. I would say I would put a possible or possibly before the provision, right? We don't know. It could be, as I said, there are two reasons. Either we did not focus on these issues as much as professionals, or in fact, it wasn't prioritized, I want to say, when it comes to providing the best possible care for these patients. And despite all of that, despite all these key findings, when it comes to the physical, the psychological, the social issues, palliative care, you saw that 3% remains, or structured palliative care, where we not only look at these somatic issues, but all of it, the entire package. Palliative care approaches, ideas remained largely absent. And also, we found that was very clear. So we still heavily rely on medication, obviously, antispastic and so forth. But also something that I forgot to mention is that when I say structured palliative care means interdisciplinary coordination between neurology, between internal medicine, between physiotherapists, between nurses, and so forth. And that coordination is still missing, right? And also when it comes to, we talked a little about how to improve assessment for palliative care in multiple sclerosis in the research setting, but when it comes to doing all that, using the potential of palliative care in the hospital setting or outpatient setting, we can already use these validated assessment tools like the IPOS in order to, you could call it, screen patients as early as possible. And this is my final note, right? It's not on the slides, but this is my final note. Palliative care is not what most people think it is, okay? Palliative care is not reserved for end-stage terminal disease. In cases like MS, for instance, where early on we know we are dealing with incurable disease, we know that we can modify the disease activity. We cannot really modify the progression. We cannot stop the progression of disease. Palliative care is a great option to use early on. And I know for a lot of people out there who just got diagnosed with MS, who don't have a lot of issues, this sounds ridiculous. But when looking at assessment tools like the IPOS, for instance, it is designed to be applied as early as possible, and is also designed to look at disease progression incrementally. You saw that over the last 3 days, what happened over the last 3 days. We can even extend that, maybe not just 3 days, but what happened over the last 3 months, okay? And tracking that as accurately as possible will give you the chance of providing these patients with the best possible care, because it is an incurable disease. We have to accept that, but we can do our best by using palliative care in order to, make sure that these patients are taken care of. Yeah, and that's it. Thank you very much. Thank you, everybody, for listening to this. I know it's not easy to follow usually. It's it's easier for me because I worked on it for 2.5 years, but I really appreciate your time. I also appreciate the opportunity of doing my rotations with AMIQT. Thank you, Dr. Stein. Thank you, Dr. Bernard. Thank you to all the staff who were incredibly helpful and friendly. And I hope that I had the ability to raise some more awareness on this issue.
Thank you. Okay. Stop it. That was great. A very, very good